This conference will now be recorded.
So my dear friends, you are welcome, okay, again, after the records. And let's see what are the important lessons that we learned from the 2020 exams. So this was really, very rich exams. So we have here the repeated question about the use of analgesic, during labor or pregnancy or even postnatal. You are all aware that there is a TUG article and there is a scientific impact paper, right? Okay, so the principles are easy, okay, when you want to apply it in the questions. However, I need you just to follow evidence as we agree. So, dear friends, if we have a patient, okay, during labor, what would be the best form of analgesic that we can offer her? What do you think? If we follow the stepwise approach or the anesthesia or analgesia ladder, okay, I can't go to epidural first for everyone, and I'll tell you why. Dear friends, you know that there is 2 or 3 even, okay, venues of delivery. Number 1, for low risk cases, it could be a midwifery unit. A midwifery unit can be either a midwifery unit by itself, only run by midwives, okay, this is for low risk pregnancies, right? And there is another venue of delivery. This is a midwifery unit, but it's alongside hospital or obstetric unit. So it's a part from the hospital, but this part or this department in the hospital is for low risk cases. And again, it's run by a midwife. Okay. Okay. So doctors, including obstetrician and anesthetist, are present in which unit? Which unit, my dear friends? In the obstetric unit, right? In the obstetric unit means in the high risk obstetric unit, high risk cases. Is that correct so far? Yes. Okay. So if the woman is present in the midwifery unit, that means who will manage their pain management? Is it the obstetrician, anesthetist, or the midwife? The midwife. Excellent. Okay. So midwives can give medications. Like what? Can you please enumerate 3 medications that the midwife can give? Number 1, paracetamol. Guys, start from the basic. Paracetamol number 1, right? Okay, so paracetamol can be given by midwife? Of course, yes. Okay, paracetamol can be given IV and can be given oral. So if the woman is early in labor, very early, like she's still at the very beginning of stage 1, okay, and she asked for pain management, it doesn't seem that like this woman is going to have a cesarean section because she's a low risk, no problem in her. What the midwife can give her? Can give her paracetamol. Okay, so if we're looking for something that's more effective than oral paracetamol, IV paracetamol can be given after oral paracetamol, right? So I can start by oral paracetamol, then followed by IV paracetamol if required, right? Is that correct? Yes, okay. Can I give non-steroidal anti-inflammatory medication during delivery? No, I can't, right? Good. Okay, very, very well so far. Okay, so my friends, what else can I offer the woman? Can I offer her in the midwifery unit pethidine for pain relief? Yes, but the woman should know that pethidine is of short duration, right? It has weaker effect uh, compared to other opioid, right? If the woman used opioids, okay, that's mean there's a risk of the baby after delivery, especially if she had the opioid near to the second stage or near to the, pass of the baby, delivery of the baby. So that's mean the woman should be aware. Of course, some cases like epilepsy, some cases like sickle cell disease, we avoid the pethidine at all, right? Good. Okay. So still pethidine can be used by midwives, and this is mentioned by in the intrapartum care guideline, right? By NICE. Well done. Okay, so paracetamol, pethidine, what else can be given in a midwifery unit? You said, guys, the gas, Intonox, right? Okay. Intonox is good, effective, okay, short duration of action, right? And it doesn't require anesthetist to be there to give it, right? Good. Okay, so there are three choices for a woman in midwifery unit. So in the exam, you have to determine situation awareness as we said before. First of all, where is the patient? Where is your patient? Patient in the midwifery unit. So think about three of these. Okay? Is that the only ways? By the way, there is strategies, of course, to reduce pain during delivery, which can be considered first, like having the birth ball, having exercise, having relaxation technique, water births. All of this can be done or can be used. But when we speak about medications in the midwifery unit, think about paracetamol, either oral or IV. Think about pethidine. Think about the gas, Intronox. Okay, three things that I will think about. So, on the other hand, the patient is in the obstetric unit. Patient is high risk. Okay, so this is for the midwifery. How about obstetric unit? Obstetric unit, high risk patient. Okay, what can you use? Can I use the same ladder? Yes, I can use the same ladder, but the epidural is considered the most effective one, right? So, for example, you have a patient, high risk in labor. Offer the epidural. Like which patient? Like the patient who had epilepsy, right? Because you want to avoid actually the stress of pain. Like the patient who had um, sickle cell disease, for example, heart disease, right? So epidural can be given to this patient. Patient who need oxytocin, yes, excellent. Patient who
Patient who
might be at risk of having, operative vaginal delivery, or you are planning for a vaginal delivery, obstetric assisted vaginal birth, like patient, for example, okay, again, heart disease, or patient who is prevented from Valsalva maneuver, patient with myasthenia gravis, patient with spinal cord injuries. Okay, so all of the types of high risk pregnancies, okay, if they have the paracetamol didn't work, if they have some pain management strategies didn't work, or they require oxytocin, then think about the epidural for those patients. Okay, guys? So the answer of the question of analgesia or anesthesia during labor will depend on number one, where is the patient? Okay, venue of the delivery. Number two, what is the risk in this patient? Okay, guys? So this is how you solve. If there is any medication that is contraindicated, please avoid it, of course. Don't put it on the option list for this patient. Okay, here we have a patient with emergency cesarean section due to fetal bradycardia. So this is after delivery, management of pain after postnatal pain management. Patient who had cesarean section and she had vomited 2 hours and she have now back pain in the wound. What is the safest management of pain in this patient? Post-operative and she had vomiting. Can I give her oral now? What she's vomiting? No. Can I give her non-steroidal anti-inflammatory now? Non-steroidal anti-inflammatory medications injection, okay, is not advised in the UK. It's advised upon discharge, for example, or after in the rectal form, after the patient had episiotomy or the patient had perineal tear. Also after assisted vaginal delivery, patient can have it while she's going home, right? So IV paracetamol will be the safest one. Can I give her morphine? We don't start by morphine ever. This is one thing, okay? Another thing is for some patients who have, yes, it will increase the vomiting, of course, and it's not one of the first medication. And also in the post-operative, I'm here not saying postnatal, post-operative, if a patient needs analgesia, actually, they will give the patient control analgesia. They will not give IV or IM. Okay, so this one is the most suitable for this patient. When the patient had episiotomy stitch and she now needs some pain management, what you will give her? Is it now paracetamol or non-steroidal anti-inflammatory? We give them non-steroidal anti-inflammatory. Why? Because it will help to reduce the inflammation and swelling in this area. Okay, not only effective for pain, but also against inflammation, right? Yes, in the rectal form, this will be the best. Again, please remember, any contraindication is a safety point. So if this patient had any history of gastric ulcer, asthma, anything, go to the paracetamol instead, okay? Can I give codeine to a patient who is breastfeeding after delivery? No. So remember again the importance of the TUG article of medication in breastfeeding, okay? Because you will find there that the codeine is contraindicated in breastfeeding, okay? Okay. Hydrocodeine could be, okay, considered. Okay, so dear friends, today in our list of the lessons, we have some infections, okay? So one of the most common infections that you can see in the exam is the syphilis, okay? Syphilis being asked in the exam from all point of view, from identifying the ulcer, what ulcer is it, from what is the organism, what is the test, okay? Interpretation of test, treatment, contraindication to treatment, alternative for the patient who had allergy, right, to one of the drugs for the syphilis. So everything in syphilis is important, okay? Okay, so dear friends, please tell me what is the primary lesion of syphilis? It's a chancre. And again, chancre is painless. Please remember, painless. What else? Indurated ulcer, right? 1 to 2 cm with moist paste and tendency not to bleed, okay? The chancre can appear anywhere in the genital, okay, and usually on the mucosal surface. It can appear on the labia, cervix, posterior, fourchette, and the glans penis. How about the lymph nodes, please? Lymph nodes are unilateral or bilateral? Bilateral, okay? Painless. Painless. So painless is painless ulcer, painless lymph node is chancre. Yes, good. So dear friends, secondary syphilis, as you can see here, can manifest by general lethargy, malaise, myalgia, anorexia, fever, headache, lymphadenopathy, usually inguinal, okay? Skin lesion can be associated with pruritus in 40% of patients. So it can be in one of the differential diagnoses of itching. Yes, it might be, okay? It's a macular lesion on trunk, pink, approximately 1 cm diameter. Papular lesion involve flexor surface, palms of the hand and soles of feet. What is the condyloma latem? It's warty lesion. Warty lesion came before an exam. Warty lesion on moist area, like vulva, or in male on the penis. Can be also manifested by alopecia. Mucus patch can be seen in 30% of cases. Also could be ulcer with white or gray border found in the oral cavity, anus, or rectum genitalia. Okay, guys. Without treatment, this condyloma can move away, okay, or disappear over 2-year period. So please take care of these lesions, okay, can come as I told you. Then the problem with most of the candidates, but inshallah not you, okay, is the syphilis test. Syphilis test, dear friends, are treponema in nature and non-treponema in nature, right? So again, I would like to ask you, for the treponema testing, which one had higher sensitivity? Treponema or not treponema? Yes, the treponema test, of course, okay? Treponema test called the treponema because it detects the antibody to the treponema pallidum, right? Okay, so it's more specific, okay? So the performance actually is not 100%, I'm sorry. So it's 70 to 90% in the primary syphilis and 90 to 100% in the latent syphilis. Okay, the question here, do you think that it could become negative after treatment? Negative after treatment? No. So that's mean if you have a patient who has been treated for syphilis before, still her TPHA or TPPA or the EIA or the CLIA, all the treponema test could be in the exam as positive, however the patient is treated. Yes, of course. Okay, how about the non-treponema? Non-treponema, okay, can be positive up to 25% only, okay? But the good thing it's have a low titer. Okay, so that's, can I quantify the non-treponemal test? Yes, you can. The RPR or the VDRL, there's two types of this test. One is qualitative test and one is quantitative. So it can give you positive or negative, or you can use it as a titer to find out the low titer or high titer. Okay, so it can be helpful in follow-up. Do you think so? Yes, of course, if you started with high tetra and you do follow up and you see that it's declining, so that's mean there is good response to treatment. Well done. Okay. Can I use the treponema testing for follow up in after medication? No, it will stay only positive. Okay, so it cannot be used to measure the disease activity. This is the treponemal test, but the non-treponemal test can be used. Okay? Which one can give you false positive result in pregnancy? Non-treponemal testing, the VDRL or the RPR, can give you false positive test, while the treponemal testing like the TPHA or the TPPA are extremely rare. Okay, so what was the classic pathway of testing the syphilis? That you might have learned this in the medical school. You might still do this in your workplace. We used to start by the VDRL, non-treponemal testing for screening, right? And when this VDRL comes as positive, we used to do a confirmatory test by non-treponemal like the TPHA or the TPPA, right? For confirmation. Is that correct? Even it was a very famous question in the past, okay, asking you about VDRL positive, what is the next step? So you choose one of the treponemal testing. This what we used to learn in the past, okay? This is might be 20 years ago, okay? So how about now? What are we doing now? Anybody have idea about what is the screening at the moment? Yes, screening at the moment, okay? It's even modified pathway from the modern one, okay? So start by treponemal serology, okay? For IgM and IgG. So what is the example of treponemal test? TPPA or TPHA or CLIA or EIA, any one of the treponemal tests to start with. If it come as positive, so what you will do. If it come as negative, what you will do. If it is negative, so everybody is happy, thank you very much, because it will never come as negative, okay, if this patient had a disease before. So thank you, bye bye, reassurance. If it is positive, no, it's not the same. If it is positive, my friends, so I will need to do a confirmatory test. Why? Because this patient might have been treated before, okay? So, and there is also chance, okay, not very high, but that this is might be, as false result. Okay, so let's confirm. Want to confirm the disease activity. So when I do confirmation, remember that I do double confirmation. Okay, so confirmation is double confirmation. What type of double confirmation that I will do? The double confirmation is number one, by sending the original sample for a different treponemal serological test. Okay, so the patient that has EIA, for example, then do TPPA and send a second sample for the treponemal serology. Okay, so you know, all of you guys, that the booking sample, okay, booking blood sample in the UK, it will kept in a storage, right? So we can go back and compare the booking sample, okay, to the recent one. Let's say a patient, for example, she had exposure, okay, to a virus now, okay. What we can do, we can compare the current blood test, okay, by the booking one, so we can see if it is recent or not. Guys, can you hear me? I think I was muted by mistake. I'm sorry. Okay, so dear friends, we have started by the treponema and we have the double confirmation by the treponema as well, right? Okay, so the confirmatory samples came as positive. What you will do? If the confirmatory samples came as positive, then please perform a quantitative RBR or VDRL test. So here comes the importance of the non-treponemal testing. For what? Baseline tetr and follow up to monitor the response of treatment. Okay, guys? So non-treponemal testing like the RBR or VDRL, okay, that will be done before starting treatment and then will be repeated every how many months? Every 3 months, okay? That's to ensure that the treatment was successful. Clear so far, guys? What else shall I do? I will do a referral to the GUM clinic or social health clinic. Why? Because this patient, by the way, she will be screened for all other STIs, okay, including partner notification and treatment and so on. Also, pediatric or neonatal care to commence a complete patch congenital syphilis birth plan, okay, because she will be referred to the fetal-maternal unit, and they will have, okay, a follow-up specialist for the syphilis in pregnancy. Okay, my friends. For the woman who declined the first test at the booking, then we can offer them or repeat them the chance of having a screening again after 3 months. Okay, dear friends, are we here clear so far about the pathway? Okay, so dear friend, is those tests are, can we trust those tests? These tests are 100% correct? Of course, no. So we have two things, either false negative syphilis serology or false positive syphilis serology. What is the chances of having false negative? This is an exam question. Okay, so what are the chances of having false negative syphilis serology? Treponemal testing are negative before chancre develop and maybe for up to 2 weeks afterwards. So if it is too early and you did the test, okay, by the treponema screening, it still can come negative. So that's why it's false negative, very early testing. A false negative, second situation is a false negative, either RPR or VDRL test. So both treponema and non-treponema may be false negative. May occur in secondary or early latent syphilis due to prozone phenomena when testing undiluted serum. What is the prozone phenomena? Prozone phenomena, dear friends, asked also before in the exam. This is a laboratory phenomena, okay? So the laboratory phenomena, which is called the prozone phenomena, this is appeal to the presence of IgG or IgA, okay, which is called the blocking antibodies. It can be eliminated if we dilute the sample, okay? So we see the prozone phenomena, in which cases in the secondary syphilis, especially for people who have HIV, okay? Okay, so again, false negative syphilis serology, like very early testing after infection, or false negative RPR or VDRL, known as the prozone phenomena, mostly seen in the secondary or early latent syphilis, especially with individuals with HIV. Okay, guys, Late syphilis also can give you false negative syphilis serology. Are we clear so far here? Examples of the false negative? Okay. How about false positive? When the test can give you positive and it's false. It can happen, of course. Okay, so in general, false positive reactivity is more likely in autoimmune disease, older age, or injecting drug abusers. Okay, so in the exam, how they bring you a question about this? Simply, they will tell you that there is a woman, for example, any medical autoimmune disorder like um, rheumatoid arthritis, okay, for example. And they will ask you, okay, about her result, okay? So it's a false positive serology can happen in this patient. Yes, it can happen. Also older age, yes. Also injection drug use, yes. Okay, so in absence of symptoms of syphilis, history of syphilis or concomitant positive anti-troponemal IgM, transient or persistent reactivity in single troponemal antigen test should be considered to be false positive result, which will be discovered by the double confirmatory testing. So clear so far? Okay, so let's read the next question, please, and see if it is clear or not. A patient presented with generalized body rash with secondary painful ulcer on vulva. VDRL, okay, was negative. So not only the VDRL, also TPHA is negative. With high suspicion of syphilis, so this is given as treponema and non-treponema negative, but clinically she looks like syphilis. High suspicion of syphilis, a repeat VDRL test is done but with higher dilution, and it was reactive with 1 in 512 dilution. The patient and husband were subjected to HIV testing and both were found to be seropositive. What we call this phenomena, my friends, that appeared as negative, okay, in HIV person, and after we repeat the test with dilution, we found that it's positive. That's a proton phenomenon. Okay. Okay. So the next question, which is again a recall question, patient with rheumatoid arthritis, RBR is positive, VDRL is negative, and the TPPA is negative. Okay. So patient initial testing was positive, but after 2 confirmatory tests, it came as negative. What is this situation now? This is called false positive test, right? Especially that the patient had history of autoimmune disease. So clear so far? I'm worried about your silence. Okay. Guys, are we okay? Okay. Okay, so what do you expect, dear friend, in a patient with normal pregnancy, low risk, okay, no clinical finding at booking? What do you expect her booking test will be? Which here he is asking you about, you know what? About your knowledge of the first step of screening. What test can be done? Of course, we expect for a low risk patient that her booking test will come negative, but which booking test? Is it VDRL negative? Okay, or TPPA negative? We would choose one of the treponema only testing. If they give you combination between treponema and non-treponema, don't choose it, please. Okay, so only TPPA negative can be the suggested result. Okay, if the patient had successful treatment, what do you expect her investigation will come as? If the patient had successful treatment, means that this patient, she had been exposed to syphilis once, so her troponemal test is likely to be positive. Yes, excellent. Well done, Dr. Maisa. Okay, well done, Dr. Noah. So, if she's treated successfully, what do you think about her non-troponemal testing? The one that we do for follow-up and quantitative. It's a VDRL or RBR. Excellent. Yes, it will be negative. Well done. Okay, friends. So now you have solved the 4 questions, okay, of syphilis that might appear in your exam. Are we clear so far? Okay, so let's revise one of the infections, okay, that comes in the exam, and it's a common question. Dear friends, this is regarding the HIV, okay? So in HIV, what do you need to remember, okay? In this exam, they asked about the post-exposure prophylaxis, okay, which is, again, by the way, repeated in 2023 exam. So post-exposure prophylaxis of HIV, how to decide for it. From the neonatal point of view, okay, those tables are very important. So they will come and ask you, a woman delivered, she's non-HIV, she delivered the baby, okay? What is the suggested regimen for post-exposure prophylaxis? How will you decide? I'll tell you. We decide the regimen based on what is the risk of the newborn, okay? So what is the risk of the newborn, dear friends? Number 1, okay, we divide this risk into very low risk, okay, and low risk and high risk. That will depend on the mother treatment, adherent to the treatment, right? And the medication that she received and for how long. Is that correct? Yes. Okay. So let's see what is the very low risk babies. Very low risk babies are babies born to a mother who used the combined ART or HEART for longer than 10 weeks during pregnancy, and 2 documented maternal HIV loads found to be less than 50 during pregnancy, at least 4 weeks apart, and maternal HIV viral load less than 50 at or after 36 weeks. Okay, so means that this baby was term, so very low risk baby must be term baby, not preterm. Number 2 is mother received the combined ART for at least 10 weeks. Number 3 is she had 2 tests negative or less than 50 HIV RNA copies per ml. And the last one, at least after the 36 weeks, at or at least after the 36 weeks. So it must be recent before delivery. So this is considered a very low risk baby. What you will give for this baby as opposed to exposure prophylaxis, this will be monotherapy in the form of zidovudine. For how many days? 10, 14, 28. Choose one, please. 14, it's 2 weeks, right? So 2 weeks of the monotherapy zidovudine for very low risk babies. Okay, low risk baby. Low risk baby is a baby that had the mother received, okay, the ART. Viral load is less than 50, but might be born as preterm. So he missed one of the above criteria. So if he's preterm, which criteria missed? Mother on the ART, she had 2 tests done and it's less than 50. Okay, so which criteria be missed? It is the maternal HIV viral load at or after 36. Okay, so now missed one of the 3 above. Okay, or the same things, but the total period of the mother treatment was only 6 weeks. So again, the same thing. Now he lose one of the 3. So we will extend for 4 weeks zidovudine monotherapy, and we call this baby low risk baby. Okay, so how about high risk? High risk babies, anything, okay? Like mother did not receive the appropriate treatment, mother viral load is 50 or more, okay? So what is the action now? You will use combination post-exposure prophylaxis if maternal HIV load is known to be or likely to be more than 50, okay, on the day of birth, if uncertainty about recent maternal adherence of viral load is not known. Neonatal PEEP should be commenced as soon as possible after birth and at least within 4 hours. Okay? In the context of known maternal resistance to zidovudine with very low or low risk, zidovudine therapy is still recommended. If high risk, combination PEEP indicated. Okay? The combination, okay, of zidovudine, lamivudine, or nevirapine. Okay, my friends? So combination will continue for how many weeks? That's good. 4. Okay, so dear friends, this is the questions, okay, that came in that exam. But however, still HIV, any part of the HIV highlighted point here in this file, okay, is important for your exam. Very important. Okay, so what is the highlighted point? One second, it takes time till it open. Can you see it now, my friends? We'll come to it, dear. Post-exposure prophylaxis, we'll come to it, don't worry. Okay, so dear friends, why combined screening test for fetal aneuploidy and NIPT is recommended for all high-risk patients? This is a question and at the start of the antenatal care, okay? So this has best sensitivity and specificity, and it will minimize the number of women who may need invasive testing. Invasive testing is not recommended and should ideally be deferred until HIV viral load has been adequately less than 50. So the question in the exam comes to you in the MRCOG. A woman had combined the screening test high risk. What will be the next? Usually, we will advise aminocentesis or CVT. Is that correct? But if this woman is HIV positive, what will you advise? Non-invasive prenatal testing at the moment, right? If the woman want to make sure, you need to check her viral load. If her viral load is more than 50 HIV, then the risk of transmission to the baby is still high. So what you will advise, that she continue on the combined ART, okay, until the viral load is less than 50 in order to have the needle test or the amniosynthesis. Otherwise, it is not advised. Okay? Okay. So how about if the patient insists, okay, like she had any reason to make her think about termination of the baby if the baby is having congenital abnormality or the baby having any other infection or Down syndrome or anything, and still her viral load is not controlled. Is there a way to do it? If there is any other way than give her the combined ART and wait? Yes, there is another way. Okay, so you will comment the CART, and it must include what medication that reduce the risk of transmission. It is the raltegravir. Okay, raltegravir is very important, okay, in this case to reduce the risk of the transmission, and be given a single dose of nevirapine. And nevirapine is very good also in reducing the risk of transmission. Okay, 2 to 4 hours prior to the procedure. Okay, so single dose of the nevirapine, how many hours before the procedure? 2 to 4 hours, okay, to ensure its activity. Also, the woman will have to start CART, but the CART, remember, there is combination of medication. One of this combination that must be present is the raltegravir, okay? Okay. So, need to remember information also about the nevirapine, that it can reach to the baby within 2 hours of the mother administration, and it can provide protection to the baby, okay? Temporary protection at this level. Are we clear so far, guys? Okay, good. How to choose mode of delivery for a woman who is known HIV patient. If you have a woman during the antenatal care and she's known HIV, how would you choose the mode of delivery? Mode of delivery will depend on the viral copies and depend on that she is taking her medication, the CART, right, correctly or not. If the patient is taking the CART and her viral load less than 50, will you advise or you will allow normal vaginal delivery or not? Yes, please. Yes, why not? Okay. If it is 50 to 399, then what you will consider? Yes, of course, you will consider pre-labor cesarean section. Well done. Okay, so if it is 400 or more, what you will advise? Yes, you will recommend the pre-labor cesarean section. Okay, so guys, when is the time of the cesarean section? This is an MQ question because this area is heavily tested in the MQ. Yes, excellent. That will be earlier, so 38 to 39. Well done. Okay, if the woman presented dear, that will depend, Dr. Noha. That will depend on the reason, okay, for the cesarean section. If the cesarean section because high viral load, okay, then it will be 38 to 39 earlier, okay, because you want to avoid that the patient comes to you in labor, and this will reduce the risk of the transmission, okay? So if the indication was higher viral load, so when to do the cesarean section? 38 to 39. If the indication was obstetric indication, but the woman viral load is low, like a woman who had HIV less than 50, okay, she is on CART, but she had breech baby, or she had previous two cesarean section. So in this case, this is called obstetric indication of cesarean section while the patient had low risk of transmission. So in this case, after the 39 weeks, like any other case. So yes, two EMQs are there, not only one. So be careful, okay? And I think that we have on the website the two examples of the EMQ, right? One with cesarean section for obstetric indication and the other one cesarean section, but because of the higher viral load. Clear so far, Dr. Noah? Okay, so any woman, dear friends, who have viral load between 50, to 1000, can I give her intravenous zidovudine in labor? Yes, please. Okay, how about more than 1000? Yes, it's offer. Okay. Yes, IV offer. IV. Okay. Is it normal vaginal delivery only or regardless the mode of delivery? What does the guideline says? The guideline says that regardless the mode of delivery. Okay. Okay. So what is the management of untreated woman presenting in labor at term? She's at term, she's untreated. So what will you consider for her? Is it only zidovudine? Zidovudine IV will be given for the duration of labor until the cord is clamped because it will reduce the risk of transmission. Okay. In this case, if the woman is not treated, right? Of course, we will advise the woman to go for cesarean section. Okay. But let's say she came already advanced in labor. So what you will advise here in this case? Here, you will need to give oral CART for additional rapid protection. Okay. For this case also, okay, you can give nevirapine. Okay, guys? So management of untreated women presenting in labor at term. All women should be given a stat dose of nevirapine. What is the rule of nevirapine in this combination? Would you give it for the mother or you give it for the baby protection? You give it for the baby protection, it can work in 2 hours. And commence oral zitidine 300 and lamivudine, okay, twice per day. Can I give raltegravir? Yes, remember, raltegravir must be present in the CART combination. Okay, can I give intravenous zitidine for the duration of labor? Yes, please. Okay, so now you have CART, okay, for the woman that include oral zitidine, lamivudine, raltegravir. Okay, IV zitidine for the duration of labor, nevirapine as a stat dose, okay, 200 mg, and remember it's for the baby mainly. Okay, guys? Okay, so do you hear my voice? Actually, Mike is not far away. Mike is in very... Okay, so please, dear, check your volume setting. Okay, I'm trying to make it louder now. Okay, so how about preterm delivery, preterm labor? If it is preterm labor, we add double dose of tenofovir. Okay, if it is preterm labor, add double dose of tenofovir. What is the concentration? It's 490. Okay, guys? Okay. Management of any woman presenting with SROM or requiring delivery in labor without documented HIV result. If the woman has no documentation of their HIV status and they came in labor, especially SROM, if they came in labor, or especially if they have rupture of membrane without documentation of HIV result, what is the action? This is a question that used to come also. I remember one in 2019. Urgent HIV test. Okay, and the urgent HIV test will be the fast test, which can give you result in how many minutes? How many? It's fast. 1 minute, 20 minutes, 10 minutes. What do you think? Yes, few minutes only, okay? Few minutes only. So, dear friends, yes, up to the 5. So if you have reactive or positive result test, then initiation of intervention to prevent vertical transmission of HIV without waiting for further or formal serological confirmation. A confirmatory test will be done, okay? Still you will do a confirmatory test, okay? And a baseline sample for CD4 count, viral load, and resistance should be collected as well, okay? But you will work urgently based on the urgent HIV test, okay? Those things will be done, but it will take more time. No problem, you're still in your plan. And remember the same regimen up there, okay, in that table. What you will do: stat dose of nevirapine, oral CART, intravenous zitidine for the delivery, and we can advise cesarean section, okay, if still there is time. Okay. Okay. So how about the delivery? Delivery will be within 24 hours, would be the aim. If the maternal HIV viral loads than 50, so immediate induction of labor or augmentation if the woman presented with SROM. Last measured plasma viral load of 50 to 399, so consider immediate cesarean section if the case came with immediate presentation in labor or SROM. If the viral load is 400 or more, so we also advise immediate cesarean section. I think this is repeated MQ in so many years so far, and you are all have experience with this type of question. Is that correct? Okay, so how about the management of SROM at 34 weeks or above? They like to ask this question. For the HIV, for the group B, for the herpes. Okay, so usually above 34, okay, we will tend to give management as term patient, okay, but remember it will require group B streptococcus in line with the national guideline prophylaxis. When the preterm occur less than 34, so in this case, remember what you will do. This is MDT decision, okay? This is MDT decision. So if the MDT decided that conservative management until 34, then it will be with the coverage of antibiotic, steroid, okay, and so on. If the MDT advised for immediate delivery, this will be also managed as immediate delivery, okay? So in exam, remember to search for where is the MDT, okay? Steroids are advised, and you know the steroid will take time. So that's mean the patient can wait, right? Okay, can you offer water birth or agree for water birth if the patient has HIV? Yes or no? If the viral load less than 50, okay, we can agree. Okay, so viral load more than 50, the woman actually will be advised to have cesarean section. Let's say she declines cesarean section, at least don't advise water birth. Okay, okay. So dear friends, here is the again in the flashcard the management for the post natal neonatal prophylaxis. Okay, the P. I hope it's clear from the flashcard so far. Okay, so how about prevention of the infection for the obstetric team, okay, who are dealing with a woman with HIV? What do you think the action will be? How will you decide? How will you decide, my dear friends? The post-exposure prophylaxis for the team. Okay, So I'll tell you guys, because there is two questions I think in this regards that I have seen before. One question for a woman who is not known to have HIV, right? You don't you don't know the status of the woman, okay, of having HIV. The and the woman herself is not known, but and also low risk. And for some reason she didn't have the HIV test. What you will do in this case? Okay, so if the woman doesn't want to be tested, you will deal with her as positive. Okay, yes, counsel, but you will deal with her as the positive one. Okay, okay. So guys, if you have been working, okay, with a case and you have injection break, okay, or needle break injection, sorry, okay. So if the HIV of the woman is known, yes or no? If yes, okay, so post-exposure prophylaxis immediately, right? Okay, as fast as you can. Of course, nobody will take it. Will take time actually, guys, till they do the basic test and registration and blah blah blah. So it will be advised to be as soon as possible in the same day, right? Okay, if the woman is not known to be HIV positive, yes or no? So what you will advise in this case? You will advise the woman to be tested, right? Okay, in the exam, I think it was 2017 exam, there was a case that she refused. Okay, the woman refused, and he is asking you, okay, whether will you take a blood sample without her agreement for the HIV testing, or you will um, start the PEP, okay, or will you wait till Monday, um, to report to the occupational health? What do you think? Or will you start the prophylaxis? You will start, okay? You will start the prophylaxis, especially, by the way, dear friends, that they give you in the exam, in this example that came before, they give you that she was asylum seeker, okay, from a country from Africa or something, okay? So high prevalence of HIV, right? And she refused testing. So what you will do in this situation? He will tell you are on Friday night. So the action will be start in the PEP. Okay, good, my friends. Okay, so let's have a look to another infection that is very common for your exam. Okay, and it will be a chance today actually for a final important final revision. Okay, so we have patient with twin, and we are asking you about the appropriate time for the GBS screening. So what do you think now, guys? GBS screening in singleton pregnancy, low risk, okay, between 35 to 37, okay, or at least 2 weeks before the time of the delivery, right, or estimated due time. So in the twin, this will bring earlier, because usually twin will have earlier delivery. So it will be between 32 to 34, okay? Where? From where the place you will get the GBS sample? Lower vagina and anorectal. Okay, this is itself is exam question asking you how to get the sample. Okay, still we have questions, okay, to come on that topic, but let's see more. Pregnant patient had a contact with a child who had measles infection. What's your plan of management? No routine for GBS, Dr. Rasmus. This is for high-risk individuals with GBS. Like a patient, for example, she had previous or known, okay, to be carrier of the GBS in the previous pregnancy. Okay, so the first thing actually, guys, after exposure is to check immunity. It's easy, right? Okay. So what is the main reason for transfer of patient from the midwifery unit to obstetric lead unit? That's delay in the first or second stage of labor, right? Delay in labor. Regarding chlamydia investigation, what are the most sensitive swabs? For the chlamydia, remember vulvovaginal swab. Okay, remember what is the vulvovaginal swab, not the test. Okay, the test is the NAT. Okay, my friends. Okay. Here, a question regarding the infection treatment. Okay, and here they will ask you about a patient HIV positive. She's on dolutegravir and with CD4 count above 350 and viral load less than 50. She came for counseling and what to know. Okay, she wants to know what? She wants to know about the fetal risk of dolutegravir. This is a neural tubal defect. Okay, so please, my dear friends, take care. This is a famous question, okay, and this one is about the important safety information from the MEHRA, okay, regarding the medication, the dolutegravir. Okay, what else do you need to take as a precaution for a patient who is on dolutegravir? If the patient got, yes, this is a high risk for nubal tube defect, so give high dose folic acid. If the woman is found to herself, okay, pregnant while she is on dolutegravir, though the action is urgent referral to her HIV physician, okay, regarding advice to stop the medication or to switch the medication to another safe medication. For women taking dolutegravir who are trying to conceive in the first trimester or in the first trimester of pregnancy, okay, so they recommended to have the folic acid 5 mg. Women for on a regimen that who don't contain the dolutegravir should take the standard recommended dose of folic acid, okay, unless they meet the criteria for higher dose. The recommendation to start the folic acid, okay, from before the pregnancy until the complete first trimester. Here, a question not on infection, okay, but I'm trying, to finish as much as I can from those questions. And here, patient on of PMS on long-term GnRH and add-back tibolone therapy, what should be done if she is on long-term? GnRH on long term. So what you will give as advice, you will advise by DEXA scan. DEXA scan every how many? Every year. Okay. Yes, she is already on at back therapy. Okay, Tibolone. So here as advise the DEXA scan every year. Naliparis in the second stage of labor in 2 hours and instrumental delivery was done. So what is the prophylactic antibiotic that you will give? That's, yes, amoxicillin plus clavulanic acid. Okay. The question here about pregnant woman with fever, okay? She presented with BROM with fever. Her temperature is 39.5 and she is known to be GBS positive. What is the treatment? For this patient, of course, we will advise immediate delivery, but we have to cover by antibiotic. What type of antibiotic need to be used? Broad spectrum. Okay, so dear friends, whenever we have a patient and she shows symptoms of infection or chorioamnitis, we advise immediate delivery with the antibiotic covered, right? Okay, so remember this fact and also remember what medication we use for the fever. We will not give penicillin, benzyl penicillin for fever. For fever management, remember, it's either we use intravenous amoxicillin 2 gram every 6 hours or intravenous cefuroxime 1.5 gram every 6 hours. Okay? If she does not have sensitivity, of course. Okay, a very famous question on the group B asking you about 37-year-old Brimy, non-GBS carrier presented with PPROM at 33 weeks of gestation. No signs of chorioamnitis. What is the appropriate management? How many weeks she is? 33. Okay, so if she is a 33, means conservative. Okay, conservative with coverage of antibiotic, right? Is that correct? Okay, so let's guys highlight, you know, read this point because it's very important, okay, and see the highlighted fact here. This is a screenshot from the guideline about the management of preterm labor, including rupture of membrane to reduce the risk of the early onset group B streptococcus disease. So how should women or known or unknown GBS carrier be managed in women with preterm if she presented with preterm pre-labor rupture of membrane? PPROM, the gestational age of importance, is the 34, right? Right? Okay. So if you have only PPROM and low risk, no other infection, nothing, okay? What you will advise? Preterm, pre-labor rupture of membrane, low risk. What you will advise? You will advise that this patient will continue conservative management with antibiotic coverage, right, until the 37, right? Is that correct? Okay. How about a patient who is having infection? Like which infection? Like herpes, for example, recurrent herpes at the time of rupture of membrane, or group B streptococcus, and this is preterm. So the guideline have found that the risk of prematurity is higher than the risk of infection, okay? But they will try to do that, okay? They would like to, outweigh the risk and benefit of conservative management in this case. So they are looking for the gestational age of what? Of the 34, when the risk of prematurity is less and risk of infection with the prolonged rupture of membrane start to increase even. Okay, so it's a balance point. Okay, my friends. So the balance point at what gestational age? At the 34. Okay, when the risk of prematurity be reduced because the gestational age is getting higher, right? And the risk of infection is increased because the prolonged rupture of membrane. So at this level, okay, they will here, okay, advise you to take action regarding delivery. So my dear friends, my dear colleague who was asking, we will give conservative management until which gestational age? What do you think? Okay, so for those with evidence of colonization in the current pregnancy or previous pregnancy, the prenatal risk associated with preterm delivery at less than 34 weeks of gestation are likely to outweigh the risk of prenatal infection. For those with more than 34, it might be beneficial to expedite delivery if the woman is non-GBS carrier. Okay, clear so far? Okay, another question about 37-year primary non-GBS carrier presented with PROM at 37. No signs of chorioamnitis. What is the appropriate management? That's intrapartum antibiotic prophylaxis and immediate induction, right? So rupture of membrane from 37, okay? This is clearly go for induction and covered by antibiotic, right? Yes, there is no need to wait actually. Okay, so another question about what is the appropriate swab in testing for a patient who is carrier for group B. Okay, so they ask about the chlamydia, they ask about the GBS. When testing for GBS carrier states, a swab should be taken from the lower vagina and from the anal rectum. Okay, a single swab for both vagina then anal rectum, or two different swab can be used, no problem. A very famous question about the antibiotic in the group B streptococcus. For women who have agreed to the antibiotic prophylaxis, benzyl penicillin should be administered. Once commenced, treatment should be given regularly until delivery. Okay, so it's recommended that 3 grams of intravenous benzyl penicillin be given as soon as possible after the onset of labor and 1.54 hourly until delivery, right? Then comes the very famous question of the sensitivity, right? And allergy. Yes. Okay. So what is the alternatives? Dr. Maisa, you're asking about patient with history of group B streptococcus. Okay, can I answer your question after we discuss the antibiotic? Okay, so vomiting only not considered as sensitivity. So the woman can continue on the same penicillin, no problem. Okay? So if vomiting only, no problem. Okay. How about if it is accompanied by non-severe reaction? Non-severe reaction means there is no anaphylaxis, no angioedema, no respiratory distress, okay? No urticaria. Sometimes they can have some superficial rash, some itching, mild, okay? But sometimes they have severe reaction. So they just said it's non-severe reaction. So if non-severe reaction, then we can think about the cephalosporin, okay? And in this case, we consider the cefuroxime, and in the dose of 1.5 loading dose, then followed by half of this dose every 8 hours. If there is severe allergy to the beta-lactams, so intravenous vancomycin 1 gram every 12 hours is recommended. Okay, friends? Okay. We have 27-year-old, low risk during her antenatal, apart from the GBS identified in urine culture at 26. Okay? And then at that time, she was being treated successfully. She presented at 39 weeks with spontaneous rupture of membrane, declined any antibiotic at labor. After 10 hours, she progressed to SVD. Regarding her baby, what is the advice? So the woman who had, as you all might know, that the woman who had presence of GBS in urine, bacteriuria, and bacteriuria is not normal, right? It's not normal that people have GBS in urine, right? Okay, especially when it is significant finding. So if the patient had bacteriuria, then treat and offer antibiotic prophylaxis in labor, right? So in our case here, okay, the patient, what happened to her? She was being treated at that time and it was okay. Then she presented with spontaneous rupture of membrane at term, okay? But she declined the antibiotic. So here, no matter what was the cause when we offer her the antibiotic, she declined. So what is the role of that case of the neonate now? For the patient who either declined the antibiotic or given antibiotic but not effective. What does the not effective mean? That antibiotics, okay, are less than the required. Like the patient came after 1 hour, she received the antibiotic. After 1 hour, she delivered. 1 hour is not enough. So we need for at least 4 hours for the antibiotic to have a full effect. So this is inadequate or declined. Okay, so here evaluation of the baby at birth, okay, and monitoring of vital signs, that will be for 12 hours. Okay, so you remember me, my friends, when we have this discussion in our course, when we used to say that we will check the baby at 0, 1, 2, and then every 2 until 12, right? So please remember, sometimes they give you not only clinical evaluation and monitoring for 12 hours, sometimes he give you the frequency of clinical evaluation. Are we clear so far? Okay, hope so. Okay, so dear friends, been asked about what about patient who was carrier in the previous pregnancy and now she came in labor. Okay, so we should ask ourselves, what is the management for a patient who was carrier in the previous pregnancy? Then we know what to do at the time of delivery, right? Okay, dear friends, if a patient had a baby affected in the previous pregnancy by the neonatal disease, okay, you must offer her antibiotic prophylaxis. Clear? No, if previous baby affected, this is no previous baby. Not only she was a carrier, previous baby. This is the first thing in the algorithm, okay? From this side. For you, could be the right side. For me, it's left side, okay? Then must have antibiotic, okay? If the patient in preterm labor, especially before 34 or intrapartum, okay, we give antibiotic. So GBS carrier colonization in previous pregnancy. What is the chances of her being carrier in the current pregnancy? So dear, 50. Okay. So we either offer her antibiotic prophylaxis in labor, we deal with her as she is GBS now, okay? Or we test her 3 to 5 weeks prior to expected delivery date, okay, and find out if she is carrier in the current pregnancy or not. Okay, friends? So we either check her status or offer her the antibiotic. So now the answer of Dr. Maisa question. Dear, what do you think? This patient who was previous carrier, she came today with PPROM or SROM or whatever, or even in labor normally, what you will do? He didn't give you any information about the current pregnancy status. You will manage her as GBS carrier. You will offer antibiotic. Okay? If she came with rupture of membrane, what you will do? Immediate induction of labor, or you will await? Yes, you will give immediate induction of labor. So clear, dear? Okay. So I think we deserve a break. What do you think? So yes, please, let's have one.
This conference will now be recorded.
Hello, my friends, and welcome back. Okay. Hopefully that you had a good break. Okay, so my friends, some of the pointers have been tested in the 2022 exams. It was about the exposure to measles, okay, and the post-exposure prophylaxis. It's actually tested before, not only in this exam, it was also, I think, in 2020 September. So if we have a patient who had been exposed to measles during the pregnancy, okay, so what is the first question that we need to ask for this patient? Whether if the woman had received vaccination or not, the 2 doses of the vaccines or not, whether she's immune or not, right? Okay, so if the woman is immune by the vaccination, Okay, so what is the advice? Vaccine immunity, what is the advice? Reassurance and tell her that the risk will be remote, and to advise her to contact the GP in. Okay, so how about now? Is the voice clear now? Okay, that's good. Okay, so my friends, what was the last thing you have heard, or shall we start? This is exposure to measles. We need to check the vaccine status. If the woman had the vaccine, the 2 doses of the vaccine, okay, or she's known to be immune, then we will reassure and tell her in the case of presence of any rash that she need to contact the GP. Clear? Okay. Then if not, if this is not the case, not the case, so check please for the IgG. IgG will indicate previous immunity, right? If the woman is immune or not. If the IgG detected, so everybody is happy, right? Reassurance, and again, contact the GP if the rash develops. If the IgG not detected means that the woman is not immune, right? If she's not immune, that means she will be at risk of infection. So what she will receive now and what she will receive after delivery. Okay, so what type of immunoglobulins, please? I need you to be more specific because the exam also is more specific. Okay, so the HNIG, what does this stand for? I remember, my dear friends, one of the revision session in with the previous batch that one of your friends told me that both options was in the exam, the immunoglobulins or the HNIG. So what you will choose in the exam? You will choose the HNIG, please, okay? Not any form of the immunoglobulins. Are we clear, guys? Okay, good. So what about after delivery? The after delivery will be the advice of vaccination, of course, right? Well done. Okay, so the patient should have 2 dose course of the MMR vaccine is advised on completion of pregnancy if the woman measles, okay, susceptible. Okay, guys. This question was in July. So a pregnant lady had exposure to case of confirmed measles. Upon asking her, she said that she had no idea if she had the vaccine for measles or not. Neither remember to develop its rash before. She is now worried about the exposure of side effect of pregnancy. What would be your initial management? Yes, so we will check the immunity. Checking the immunity mean check for the IgG, right? Okay, so this one is EMQ about the presence of rash and the characteristic of rash. Okay, so this EMQ is about pregnant woman who traveled from Sri Lanka, and she gave history of nose bleeding twice in her way back, feeling unwell with joint ache, epigastric pain, and severe headache. Okay, so if she had nose bleeding and severe headache with epigastric pain, that means what type of fever is it? This is hemorrhagic one. Yes. Okay. So which hemorrhagic fever could be present in Sri Lanka? That's dengue fever. Okay. And if you just search it online, you will find that there is a travel warning in the last year. Okay, guys. So this one is dengue fever. Well done. Okay. So a young woman came for termination of pregnancy with flu-like symptoms. She developed rash in the upper part of the body, bloodshot watery eye, barky cough with joint pain. So this is looks like what? Which infection have the barky cough and with the bloodshot eyes? Red eyes, cough, barky cough, fever, white spot. This is measles. Okay. How about varicella zoster? What is the varicella zoster there? Varicella zoster is chickenpox. Chickenpox is very easy to identify. Why? Itchy vesicular rash. Okay? So itchy vesicular rash, there is no other choice. You will go for the varicella. Okay? Okay, guys. So a teacher with history of travel to East India to attend the school tournament, and she developed itchy rash all over her body. According to the type of rash, my dear friend, we can say it is lace-like rash, which can be itchy, or it's a vesicular rash with flu-like symptoms and itching. I wasn't in that exam, to be honest. Okay, so I don't know what type of rash is there. However, it's very easy when we discuss about rash that can be itchy and all over the body. We either have parvovirus or we either have varicella. Okay, and both are common in school student. How to differentiate between both of them? Vesicles. Okay, so vesicular rash is varicella. Non-vesicular rash, lace-like rash, can be itchy as well. This is parvovirus. So clear so far, my friends? Okay, so the only way, dear friends, to answer this question correct is you know that what are the characteristic of each infection. Okay? So you will need to study a little bit about, or to remind yourself a little bit with the clinical picture of each infection. Here is some notes about the dengue fever, okay, which is viral infection that can spread by mosquito, and it's widespread in many parts of the world, okay. And the symptoms are high temperature, feeling hot or shivery, severe headache, pain behind the eye, muscle and joint pain, feeling or being sick, widespread red rash, tummy pain, and loss of appetite, okay. It can be severe, and in this case there will be severe abdominal pain, swollen tummy, being sick repeatedly and vomit, blood, bleeding gums or bleeding under the skin, breathing difficulty or fast breathing, cold or clammy skin, weak but fast pulse, drowsiness or loss of consciousness. This is for the very severe cases, okay. However, let's have some of the information about the varicella, sorry, the rubella first, then we'll come to the varicella. Rubella is rash, typically start on the face, neck, before spreading down the body, okay? Then become generalized. The rash is pink or light red, maculopapular, or usually present for 3 to 5. Associated with lymphadenopathy, okay, which can be post-auricular, uh, behind the ear, or cervical, or suboccipital. May precede rash and last for 2 weeks after the rash actually resolved. Can be accompanied by arthritis, arthalgia, more common in adult women. Non-specific symptoms like low-grade fever, headache, malaise, nausea, mild upper respiratory tract symptoms, and non-purulent conjunctivitis. Rubella should be suspected in people with clinical picture consist with infection with risk factors such as incomplete immunization or no evidence of the previous infection. History of exposure to contacts with rubella within the last 3 weeks, or travel to an area endemic for rubella. Low threshold of suspicion for rubella in pregnant women is essential. Rubella must always be excluded in pregnant women with rubella like rash. Even other causes are more likely, and regardless of previous immunization history. So, dear friends, when there is rash, okay, non-vesicular rash, patient must be tested for rubella. It's a notifiable disease, means that you have to notify to the local health protection team, okay, and by this, okay, their role is to notify it, okay, to the authorities. Dear friends, please read, okay, about the clinical picture. Remember the easy way to diagnose the rashes. Varicella is vesicular rash, V with V, easy, right? Parvovirus, common in school children, but the rash that appear, okay, that will be lace-like rash, and it can be itchy as well, okay? Maculopapular rash. Anything that have bark, cough, red eyes, fever with white spot, it's measles. Joint pain, hemorrhagic fever, severe headache, abdominal pain is dengue. Are we clear so far, guys? Okay, so we almost can say that there is no exam without herpes. Okay, so let's have a look, guys, on the most important thing, or the most important question that comes from herpes. However, I would say that the whole guideline of the herpes infection in pregnancy is important. Okay, so every point in the guideline is important. Please, guys, make it one of your very hot topics for the exam. Revise it. Today you have to revise the infections, of common infections that comes in the exam, especially MQ, like syphilis, HIV, and group B streptococcus, also the herpes, please. Okay. Okay, so every point in the guideline of herpes, it's a small guideline, however, very important. Okay, every point in the guideline of the herpes comes in the exam as one question. Okay, so we have a lot of questions regarding the herpes, but first let's have a review, okay, of the herpes management. Do you remember the algorithm of the herpes? Algorithm regarding the primary infection, the secondary infection, how to manage it. I think we have just revised this one recently, right? I'd like to remind you again, the algorithm of management of herpes in pregnancy and care of the neonate, right? It was yesterday or in the previous one, day before yesterday. So recurrent herpes, aim for vaginal delivery, advise the low dose from how many weeks? From 36 weeks. How about primary? Yes, according to the gestational age. So how about primary in first and second trimester? Treat at the time, okay, of the acute infection, and then after that deal with it as a recurrent. Okay, give prophylaxis from 36 and aim for vaginal delivery. Okay, how about primary in the third trimester, especially last 6 weeks? Treat and continue the till delivery, right? What is the aim of delivery? It's about the cesarean section. Please don't forget the revision of the neonate in this same algorithm. Okay, so again, the algorithm is super important. Okay, common point to be asked in the exam, other than the management of the algorithm and the neonatal, I mean the delivery and the neonatal exposure. Okay, they sometimes ask you question regarding management of the woman who is HIV positive with herpes infection. Okay, so what you will do, the woman had co-infection. If it is a primary infection, so HIV woman with primary genital herpes infection in the last trimester of pregnancy should be managed according to the recommendation of the woman with primary genital herpes. No change, okay? So same advice. How about the recurrent? The difference, my dear friends, in the recurrent is that we will start the protection, the low dose protection for this woman earlier. Since how many weeks? Normally, we start 36. In HIV individual, when to start? You will start at 32. Okay? Clear. And the management of delivery, by the way, choice of the mode of delivery will depend mainly on the HIV status, viral load, and according to the HIV. Okay? Because it's a recurrent infection, so you're not worried about the herpes, you're worried about the HIV. Okay. What is the second point that they like to ask? They like to ask about the genital herpes in preterm, pre-labor rupture of membrane before 37 weeks of gestation. Okay, so if the woman had PPROM before the 37, what is the advice? If this is primary, okay, and the woman came with preterm, pre-labor rupture of membrane, there will be MDT to decide, okay, about what is the management. What is the MDT action they will do? They will decide regarding the management. If they decided for conservative management, okay, then what the woman will receive? That will be intravenous acyclovir 5 mg per kg every 8 hours. Please know the doses. Prophylactic corticosteroid should be considered, right? If the delivery indicated within 6 weeks of the primary infection, then delivery by cesarean section may still offer some benefit despite the prolonged rupture of membrane. Clear so far, guys? Okay, how about recurrent with PPROM? Recurrent with PPROM, then we will go to the rule of the 34 weeks. You know, do you remember that rule? Okay, same as the group B streptococcus. Before 34, the evidence of suggests that conservative management is better because risk of prematurity is higher than the risk of infection, right? But the woman will be receive prophylaxis in the form of oral acyclovir. Okay, so they like to ask in the exam oral or IV. Okay, how many times? 2 to 3, 4 mg TDS. Okay, so this will be until how many weeks? Then after that we can discuss the labor. This will be until 34, then after that the decision again will be by the discussion. Okay, so they will try to outweigh the risk of continuation the pregnancy or the risk of the delivery. Okay, so they will discuss it as well. But from 34 to 37, why not to deliver? Delivery could be considered or otherwise conservative, but there is no actually clear cut off. Okay, because it will be individualized the management. So dear friends, I need you to remember, okay, those basic information, revise the point of the MQ, okay, from the herpes, so many times you need to revise it, okay, and after that, let's go and revise the emergencies, okay. What emergencies that we are going to revise today that recently came in the exam? We do have neonatal resuscitation, and we do have cardiac arrest, okay. So is that important for your exam? What do you think? It is important for your exam, okay. So let's please have a look so you will be ready for that question when it comes. This is according to the UK neonatal support, neonatal life support, okay. And here we will start by the birth, advice for birth, okay. So advice for delay cord clamping if possible, unless the baby is actually distressed, okay. Then start clock and note the time. Dry, wrap, stimulate, and keep the baby warm. Then assess for color, tone, breathing, heart rate. Then ensure that the airway is open. Okay? This is regarding the term babies. We'll speak about the preterm in a minute. So if the baby is not, if gasping or not breathing, then give 5 inflations. What is the pressure? 30. Pressure is important for exam. 30 centimeter, okay, of H2O. Start in air, okay, then apply PEEP 5 to 6 cm H2O if possible. Then apply SpO2 plus or minus ECG. Then reassess the baby. So we will start by the airway, breathing, and then chest, A, B, C. For the chest, okay, check if the chest is not moving. If the chest is not moving, check mask, head and jaw position. Then two-person support. Consider suction, laryngeal mask, or tracheal tube. Repeat inflation breaths and consider increasing the inflation pressure. So we are still checking that the air entry, okay, to the chest is okay. Then reassess. No increase in the heart rate or look for the chest movement. Then once the chest is moving, continue ventilation breaths. If the heart rate is not detectable or less than 60 per minute, and here please guys take care that we deal with the heart rate in the neonate when it is non-detectable as the same as less than 60, okay? Severe bradycardia. So after 30 seconds of the ventilation is secured, then in here you need to synchronize 3 chest compression to 1 ventilation. So what is the rate of compression to ventilation? 3 to 1, okay? Increase oxygen to 100%. Consider intubation if not already done, or laryngeal mask if not possible. Reassess the heart rate and chest movement again every 30 seconds. So every how long you will reassess? Every 30 seconds. If the heart rate remain non-detectable or less than 60, then vascular access and drugs. Okay, consider other factors like pneumothorax, hypovolemia, or congenital abnormality. So here he said vascular access and the drugs. Which drugs can you give in the neonatal resuscitation? Something to stimulate the heart. Okay, so everyone would like to give adrenaline. Okay, so dear my friend, okay, for preterm neonate less than 32, okay, you place them undried in plastic wrap plus radiant heat, okay, inspired oxygen from 28 to 31 weeks, 21 to 30%. If less than 28 weeks, then 30%. If you are giving inflations, okay, with a neonate less than 32, then the pressure here will be 25. So in exam, look to the gestational age of the neonate. If the gestational age 31, then what will be the pressure to give the 5 inflations? 25. That's why you will find it in the choices. Give 5 inflation 30, give 5 inflation 25, and so on. Okay? Clear so far, guys? That's very easy, right? Okay. So one question here. A midwife called you that the baby just delivered to a 19-year-old primary. Baby was not responsive. Baby was floppy and had no respiratory effort, but heart rate was 64. What is the single most important next step? Which of the following is true? Okay, so please choose. What are you going to do? When there is no respiratory effort, what you will do? Okay, so guys, are you aware what is the inflation time? So the choice number one says 5 inflation press should be delivered lasting with an inflation time of 5 seconds. I'll tell you the normal inflation rate is 2 to 3 seconds. Each one is 2 to 3 seconds. Okay, good. Okay, so how about E? E, say ventilation press, same as inflation, should be delivered at the rate of 30 press per minute. Yes, so here E is the correct one. So he tricked you by what? He tricked you by giving you the 5 inflation press to make you just go and tick it. Okay? So the answer is E. Yes. By the way, this question came in the exam, but it's originally a strategy question. So a midwife called you because the baby had delivered to a 34-year-old primey. Baby was not responsive. Baby was flippy and had no respiratory effort, but heart rate was 56. So here heart rate is 56 only. What is the single most important next step? Single most important next step. With the heart rate less than 60, remember chest compression is required, right? So chest compression rate is 3 to 1. Excellent. Excellent, my dear friends. Okay, so another question, dear friends, asking you about the epinephrine dose, okay, used in neonatal resuscitation. Epinephrine dose. The intravenous, okay, or intraosseous epinephrine dose should be 20 micro per kg, okay? Okay. Another question from the neonatology, okay? They like to ask neonatology question in this year, so be careful. 30-year-old primey with background of anxiety went into spontaneous labor at 38 weeks following 2-day history of rupture of membrane. Following a slow progress of labor, she had a difficult venous delivery. The baby developed a large hematoma post-delivery. The infection marks in the baby were normal. Which of the following aspect in maternal history is most likely to increase the risk of neonatal jaundice? They like also the question, previous question about the kefal hematoma, ask you what is a kefal hematoma? It is subperiosteal collection of blood secondary, right, to the trauma, right? Yes, excellent. Thank you very much. So that's because of the difficult birth. Okay, so pregnant with episode of supraventricular tachycardia. What is the preferred drug to terminate this episode and what is the route? supraventricular tachycardia. That's the adenosine, and the route is IV, right? Valsalva is not medication, right? It's the initial action till you get the medication. Okay, so my dear friends, if they ask you about how to prevent this episode, how to prevent the episode of the supraventricular tachycardia? By beta blockers. Okay, so for prevention, beta blocker. For treatment of episodes is adenosine intravenous. Okay, okay. So a pregnant mother collapsed because of anaphylactic shock. What is the preferred drug to terminate this episode, and what is the route? Anaphylactic shock. Intralipid, dear Dr. Fadli, intralipid for local anesthesia. What is intralipid? Intralipid, guys, it's the local anesthesia, toxicity. What is, you're confused. Okay, so no problem. Adrenaline, IM. Okay, so dear friends, safety of the medication that used for the arrhythmia. Okay, and the possible complication and breastfeeding advice. One medication, okay, can be used for short term in emergencies, but avoided in breastfeeding women. Avoid in long term in breastfeeding women. What is the medication? This amiodarone. The amiodarone is known to have effect on the fetal thyroid gland, can cause abnormality, growth restriction, and prematurity. So risk outweighs the benefit. How about beta blocker? Is it safe or not safe? Safe. Okay. What complication of beta blocker that came in the exam, in last exam, in the fetus? Hypoglycemia, hyperbilirubinemia. Okay. Bilirubin is high, glucose is low. As I told you guys, the effect of the medication on the neonates or fetuses in breastfeeding is important. Okay, so recently we have seen so many questions regarding the medication safety, right? The amiodarone question is very famous question. It's old, but it was famous. And beta blocker question came recently in the exam. Let's have a look on the cardiac arrest, guys, and see what are you going to do, or what medication that will be received for cardiac arrest patient. The obstetric cardiac arrest algorithm. Obstetric cardiac arrest, okay? This was published by the Royal College along the cooperation with the Resuscitation Counseling UK in the last embrace. Okay, so First, confirm the cardiac arrest and call for help. Declare that this is obstetric cardiac arrest. Of course, this will have a specific code, okay, to call. Team for the mother and team for the neonate. If the neonate is more than 20 weeks, will be available, okay? So this means require drills, okay, and the training on how to manage the obstetric cardiac arrest. Why it's important in the exam and the neonatal resuscitation? Because guys, this is basic. Those are basic skills, okay, for the obstetric team. Anybody who work in the obstetric team will have the basic training on the obstetric cardiac arrest and the neonatal resuscitation. So it is not a guideline, okay, it's training that's mandatory and it must be updated, okay? So people repeat this training every year to make sure that they are ready for the practice and they are aware by the update. So do you. You must also be ready. So lie the patient flat, apply manual uterine displacement to the left or left lateral tilt 15 to 30 on a firm surface. Comment CPR and request cardiac arrest trolley. Standard CPR ratio and hand position, okay? Evaluate potential cause. So potential causes like hypoxia, hypovolemia, hypo or hyperkalemia, hypothermia, the 4H, or the 4Ts like tamponades or thrombosis, toxins, or tension pneumothorax. Anybody or any of these. So in the exam, if he give you a hint about what is the cause of the collapse, please consider management of the cause along with the resuscitation. Okay? So apply the defibrillation pads and check cardiac arrest. Defibrillation is safe in pregnancy and no changes to standard shock energies are required. If VF or pulseless VTAC, then defibrillation, okay? And first adrenaline and amiodarone after the third shock. So again, my friends, this was MQ question in 2022. You could have the same question in the exam or not. You can have another modification of the question. So be ready of whatever possibility can come to you. If you have patient with VF or pulseless VTAC, what is the response? First is apply defibrillation. Then adrenaline first. Then after third shock, what you can give? Amiodarone. Clear so far or not? How about if we got asystole? The asystole means resume the CPR and give first adrenaline immediately. Okay? So if he give you, my friends, again, if he give you a case, okay, but not VF, not VTAC, he give you asystole or PEA, okay? So what you will do? Pulseless electrical activity or asystole. CPR and adrenaline. If it is pulseless or asystole, do you think that defibrillation have a role here? Yeah, so in the guideline, we have shockable RESM or non-shockable RESM here. In the cardiac arrest, he is telling you what type of the Then, my dear friends, you need to check the rhythm and pulse every 2 minutes. Every 2 minutes while the CPR is continued, right? Then repeat the adrenaline every how many minutes? 3 to 5. Okay? Please maintain airway and ventilation. Give 100% oxygen using the back valve mask device. Insert supraglottic airway with drain port or tracheal tube, okay, if trained to do so. And of course, in pregnancy, you know that intubation may be difficult. Apply waveform, capnography monitoring to airway, and if expired CO2 is absent, then presume esophageal intubation until absolutely excluded. For circulation, maintain IV access above the diaphragm. If fails or impossible, use upper limb intraosseous. Okay? About the medication, please let's have a look here, okay, for the medication used. Medication in box B, this is with the blue color. IV drugs for use during cardiac arrest. Fluids given is 500 ml IV crystalloid bolus. Adrenaline will be given by the dose of 1 mg IV every 3 to 5 minutes in non-shockable or after third shock. Okay? Amiodarone 300 mg IV after third shock. Atropine 0.51 mg IV up to 3 mg if vagal tone likely is the cause. Calcium chloride. This is antidote to what? To the cases collapsed from what? Okay, what is the other preparation of calcium can be given also? Calcium gluconate. Okay, 10% of 10 ml IV for magnesium overdose, low calcium or hyperkalemia. Magnesium, okay, if required, this is for hypomagnesemia, okay, or polymorphic VT. It will be given as 2-gram IV. If it is magnesium for eclampsia, so what is the dose for eclampsia? 4-gram slowly IV. Tranexamic acid will be added in hemorrhage. Okay, intralipid for what? Which case is not for everyone? Intralipid for local anesthetic toxicity. Thrombolysis, okay, can be given in case of suspected massive pulmonary embolism. Okay, so guys, you have tried to identify the cause, you have tried to resuscitate, however, there is no response. After 4 minutes, what shall you do? Perimortem cesarean section. Okay, so the perimortem cesarean section will be performed if 20 weeks or more, no improvement to the situation after the CPR. It should be done on the scene. You don't need to go to theater. Somebody else should continue the CPR, okay, and should be done within 5 minutes, okay. And if the baby is more than 22 weeks, will be handed to the neonatologist, right? Post resuscitation from hemorrhage, okay. Please remember the massive hemorrhage protocol, okay, like giving neutropenic drugs like tranexamic acid, consider fibrinogen, cryoprecipitate, and so on. So, okay, guys. So manage hemorrhage as it came in the postpartum hemorrhage. Still, some question come from this cardiac arrest, and some question comes from the maternal collapse algorithm in the guideline. Okay, it is almost very similar, but some information comes from that guideline algorithm. So they want to ensure that you are also studying the guideline. So patient collapsed. Okay? Stimulate and assess response. Ensure the manual uterine displacement or left lateral tilt. Call for help. Assess breathing, pulse, blood pressure, fetal heart. Okay? And identify cause of the collapse and direct management. If the patient responsive. If the patient is not responsive, then shout for help for the resuscitation team. Open airway. Assess for breathing up to 10 seconds. If not breathing, then start CPR. Okay? In cases of cardiac arrest in the hospital, adrenaline, okay, for the resuscitation, after you are doing the resuscitation, will be given IV. Okay? In the cases of the cardiac arrest and you are doing resuscitation, for what condition? Asystole or after defibrillation. Okay, in cases of VF or pulseless VTAC, adrenaline will be given IV. In cases of the anaphylaxis, okay, patient have received antibiotic. Okay, she started the anaphylactic reaction. What you will do? The IM. Okay. So, dear friends, here, let's continue. When we found that the patient is not breathing, then CPR. The rate of CPR is exam question. What is the rate? 100 per minute. We give 30 chest compression in a rate of 100 per minute. Okay? Ensure that this is effective compression by making sure it's deep at the center of the chest, 5 to 6 cm. Then 30 chest compression to 2 ventilation. What was the rate in the neonate? Neonate was what? 3 to 1. Excellent. Okay, so here we have 32 2. Okay, rate per minute is 100. Both are coming in the exam, so please take care until the defibrillation or the monitor attached. Okay, attach the defibrillator, assess the rhythm. If the rhythm is VF or pulseless VTAC, give one shock. The one shock can be either 200 joule biphasic or 360 joule monophasic. Then continue CPR 30 to 2 for 2 minutes. Are we clear so far? Okay. If it is asystole, is there any rule for the defibrillation? Continue the CPR for 2 minutes in the rate 30 to 2. Okay, guys. Here he is telling you during the CPR, establish IV access. Of course, this is the team while doing this. High flow oxygen, intubate, and then give continuous chest compression. Correct reversible causes. Give adrenaline every 3 to 5 minutes if not responsive yet. Consider amiodarone, atropine, and magnesium according, of course, to the case. Are we clear so far, guys? Okay, so please take care. Okay, you do have 3 emergencies algorithms that you need to study. Okay, the cardiac arrest, maternal collapse algorithm from the GTG, and the neonatal life support. Okay, thank you very much, guys, for your attendance today. Hopefully that we have learned some lessons from the 2022 exam, and it is going to help you, inshallah, in your next. Thank you. Thank you very much. Your feedback also is highly appreciated, so I will welcome your feedback and comment. Thank you.